So why don't we go through this together? So I'm just going to look for the OGD. Great. So this is explanation. This is a station. They will write, you do not need to take the consent, but they're testing you whether you can take the consent or not. The reason they write you do not need to take the consent is because writing down the consent itself takes about 10 minutes. You've got only 10 minutes, 9 minutes at the station. So let's go through this together. And first of all, by looking at the consent form. This is a typical consent form, either consent form 1 or 3 that we use. One, the first section is the details of the patient, male, female, and the name and the patient's NHS number or the hospital number. And this part is the patient's consultant name and the job title consultant and responsible person. The next is the proposed course of treatment. In this case, it would be OGD. The next, why are you doing this, meaning intended benefits, followed by seriously occurring risk. So intended benefits, most of the time, it's the therapeutic and the diagnostic purposes, just to diagnose it and then treat it. Ultimately, it will improve the quality of life for the patient. Right? Seriously occurring risk. So there's a question that I usually ask, should you include mortality? Can the patient die from OGD?
No, really unlikely. Very, very
The
highly
answer
unlikely.
is yes. Can the patient die from the OGD? The answer is yes.
Yes.
But did you include it in the
0.
consent? The answer is why?
0.05%.
So it's
It's
very low.
less than 1%.
It's less than 0.5%. So it's very low. The rule of thumb for including the risk is you have to include all the commonly occurring risk and a very serious risk that happen more than 1% of the time. 1% is usually the rule of thumb. So what we're going to talk about is the usual things like the bleeding, damage to the linings, and the infection, chest infections, and such, etc. And then tear of the esophagus as well. Right? And then the next thing is if you're going to do any additional procedures, then you have to write it down. In this case, you might write down a balloon dilatation as well. Right? Afterwards, you tick either local, sedation, general anesthesia, and then you sign it. Your job title will be registrar most of the time. If the patient doesn't speak English and you have to use an interpreter, the interpreter will sign it. Or if you're calling interpreter over the phone, then they ask the contact details and write it. Statement of the patient understands and this and this and that, and then they will write it, yes, I understand it, and then sign and then print the name. Right? And then if there is a witness involved for a complex procedure, so you can ask them to sign it, but this section we don't usually use it. Lastly, confirmation of the consent. Let's say the patient came in today for OGD, but for some reason OGD is cancelled and scheduled for tomorrow. This patient comes in the next day. Sorry. You do not need to take the consent again the next day. All you need to do is sign this confirmation of the consent and proceed with the procedure itself. You can do it usually up to 7 days, but after 7 days from the initial date of consenting, you have to do a new consent. So these are pretty much the sections of the consent form. This is the consent form 1 that we usually use, right? So let's go back to here. So first of all, we're going to start by explaining the procedure. And important thing for you to note is you cannot use medical jargon. You have to use layman terms completely. So OGD, it's a tube the size of a finger with a camera attached to it, and the camera projects images onto the TV monitor, and it will be introduced into your mouth, food part, stomach, and sometimes first part of your small bowel to visualize them. The next section of the consent form, if you remember, is the intended benefits, and I said diagnostic and the therapeutic purposes, ultimately improving the quality of life. So that is to, again, don't say diagnostic purposes or therapeutic purposes to the patient. We have to explain it to the patient that to diagnose the problem and treat the problem if there is any, if we can, then and there, ultimately improving the quality of life. No procedure is without risks. Again, this is the exact words that I use. I've been using for so many years in real life when consenting the patients as well. Reaction to the sedatives, damage to your teeth, sore throat, chest infections, bleeding, damage to the lining of the food pipe. Highly unusual but one serious risk is the tear of the foot pipe, which may require surgery. And towards the end of mentioning the risk, always mention about the reassurance. Mentioning these doesn't necessarily mean these will occur. Only experienced and trained people will perform the procedure. Always make a habit of reassuring towards the end of the procedure as well. One of the questions the patient could ask is there any alternative? What's the alternative to the OGD?
Barium swallow.
Barium swallow. Is the CT alternative?
No.
Why?
CT won't get a precise location, and I can't be therapeutic.
If there's a tumor, CT is the best scan to look at the precise location of the tumor. But why CT is not an alternative? Because CT is an anatomical scan. CT is simply taking a picture at certain time of the certain structure. The more prominent example would be arterial duplex versus CT angiogram. If you look at the CT angiogram, you are taking series of pictures and such, but arterial duplex, that's a physiologic scan, meaning there is a flow, you can detect the flow, you can detect the pressure, and you can see how much flow is going in. A very narrow vessel doesn't necessarily mean compromising the blood vessel, blood supply. So the same thing here as well, OGD. It's a kind of like a relatively functional scan rather than pure anatomical scan. That's why CT is not a alternative. But barium swallow, on the other hand, if you take a series of pictures while the patient's drinking some dye, then you can talk about it. But one of the alternative is the barium meal X-rays or simply barium swallow. We are taking a series of X-rays while you are drinking a liquid dye that is visible on the X-rays. Of course, we cannot directly visualize the food pipe or the small intestine, and more importantly, we won't be able to get tissue samples from it. If it's positive, you would probably need to undergo OGD anyway. So that's why it's important to have the OGD, better to have the OGD in the first place. During the procedure, any dentures, tongue piercing should be removed. And most of the time we'll do a throat spray. Not tolerating, the next step would be sedation, not tolerating general anesthesia. And we'll explain that OGD tube will be inserted into the mouth food pipe to perform the procedures mentioned above. So what is the layman term for sedation?
Numbing agent, maybe.
That make you relax.
A relaxing agent.
Medications to make you feel relaxed. Relaxing medications. How about general anesthesia? What's the
Numbing
layman term?
agent.
Medication that put you sleep.
Numbing agent is the local throat spray, is a numbing agent.
Yeah.
Okay, medications that make you not aware of what's happening around. Maybe.
That put you to the sleep.
That is the keyword that we usually use, is put you to sleep. Patient will go to sleep. So after the procedure, the patient goes to the recovery area. When can the patient go home, by the way? Let me ask you before I open this up.
It is local spread that patient can go on his own at that time. After we using sedative drug, then patient can we will observe the patient for 2 to 4 hours for a vital, and then he can go. But there is some precaution. He cannot drive for next 24 hours, and also will know he will not sign any legal document, and will avoid using hard liquid or drink. And yes, and if the patient is
How
using
about GA?
then we can keep the patient for overnight stay and discharge on the next morning.
Correct. So if it's a local throat spray, they can almost go home immediately on their own. Very important thing is that sometimes they drive to the hospital. And if they end up having sedation, they cannot drive for the next 24 hours. That's an important thing, right? If they had the sedation, you need to monitor in the recovery area for the next few hours, usually about 2 hours, 1 to 2 hours or 2 to 3 hours, depending on how the patient's doing. But if the patient's had the GA, the patient will have to spend in the hospital for the night. You have to keep in and monitor for a day. Post-procedure advice, this is for sedation. Of course, local throat spray, you don't need much. For the sedation, please do not drive for the next 24 hours. Do not operate heavy machinery. Do not sign any legal documents. Do not go to work. Do not drink alcohol. Do not drink very hot or very cold hot drinks. Do not look after young children on your own. This is the classic advice that we give for the sedation patients. Towards the end, if the patient says thank you, it's not the end of the conversation. Many of the time, what you have to say is the patient's going home, then you have to talk about the safety net. In this case, please seek immediate medical attention, meaning where does the patient go?
Nearest emergency.
Emergency department, right? Not GP. So go to nearest emergency department if you've got severe chest pain, if you've got high temperatures, if you start to have shivering episodes, difficulty breathing, and if you don't feel right, please go to the nearest emergency department.